Thank you so much for being here. I'm Amy Gorin. I'm the director of InCHIP, and I welcome you here on this rainy afternoon. And I also welcome the folks that are joining us online. And also, I believe UConn TV and radio are also going to be picking up today's activity, so I appreciate that. I'm so glad that you're here. We're celebrating and recognizing World Mental Health Day. And we actually have two events today, our lecture, which I'll introduce our speaker in a minute, but we also have an event this evening at 6 p.m. in the Student Union Theater, and it's entitled Lonely Campus, Social Connection in the Age of Digital Despair. And this is a panel discussion that we've put together with our partners at Counseling and Mental Health Services, who actually worked on this whole day of programming with us. And the panel is going to feature Betsy Krakow, who's the Director of Counseling and Mental Health Services, Gina Barreca, who is a distinguished professor of English and is writing a book on loneliness. And then we're going to have two students who are going to share their personal perspectives on social connection on the UConn campus. So I hope many of you can join us at 6 p.m. tonight. So turning now to our lecture, I'm thrilled to introduce to you Dr. Julianne Holt-Lunstad, a professor of psychology and neuroscience at BYU, and one of the leading experts in the world, if not the leading expert in the world, on social connection and its relation to health outcomes. Her groundbreaking work has firmly established social isolation and loneliness as risk factors for early mortality. And she has taken a leading role in communicating this not just to scientific audiences, but also to policymakers and the public. She has provided expert testimony to folks like the US Congressional Hearings. She's worked with the US Surgeon General on this. She just came from the UK, where she's working with their cross-departmental loneliness team, among many other entities who can hopefully make a difference in really connecting people in a meaningful way to others in their lives. Dr. Holt-Lunstad has received numerous awards for her pioneering work, and she's widely cited by both her scientific colleagues and also in the popular press. Consistent with the findings that we're going to hear about today, our own Counseling and Mental Health Services has embraced the theme Connection as Prevention, which I now see is also the title for today's talk. So this is a theme that has been ongoing here on the UConn campus to really highlight the positive impact that social connection can have on mental health. So when it came time for us to identify a speaker for World Mental Health Day, Dr. Holt-Lunstad was clearly the obvious choice for our audience. So we're incredibly fortunate to have her here on campus today and hear from this internationally recognized speaker and leader in the field about how connection to others is intimately tied to both our own mental and physical health outcomes. Please join me in giving a warm welcome to Dr. Holt-Lunstad.
Thank you for that kind introduction, and thank you all for attending. I know that there's lots of competing demands on your time, but I am so happy to be here, and I love the theme, Connection is Prevention, and I hope that you see how that ties to what I'm going to be talking about today. So most of us, it's widely recognized that our relationships influence our emotional well-being or psychological well-being. But what I'm going to talk about today is how this can also impact our physical health as well. So if you're wondering what this giant blob is, it is a group of starling birds. And what we can see is that across a number of species, being part of a group can serve some really vital functions. So whether it is efficiency or direction to safety, evading predators, pooling of resources, protection from the elements, reciprocal altruism, obtaining food, or even warmth and comfort, we see that across a number of species that being part of a group and being connected to others can serve vital functions related to survival. This has led many to argue that social connection is a fundamental human need and even a fundamental biological need. and has also led the late John Cacioppo to argue that conversely, loneliness is much like hunger and thirst. The biological motive but in the case of loneliness, it's a biological motive to reconnect socially. Neuroscience supports this idea that social connections may be a biological need. So for instance, when faced with a threat, we use more metabolic resources when we are alone than when we are in the presence of others, particularly trusted others. There's also some evidence from neuroscience to suggest that social pain and physical pain may have similar neural pathways. Indeed, social isolation is so distressing that it has been used as a form of punishment and even torture. We also are seeing a number of headlines around the world with news headlines suggesting that loneliness is a modern-day epidemic. Some of these headlines come from the US, the UK, Australia, Germany, among others. In fact, the UK, as was mentioned, has even appointed a minister for loneliness, which I actually just met a couple days ago. And yet, when this appointment occurred, in the US, the news headlines were either confusion around this, or was the butt of jokes by late-night comedy shows. And so we also know that most medical organizations and the general public do not widely accept this as something that is important to one's health. So the question, of course, arises, what is the level of evidence to support this? And is this something that we should be taking seriously? So what I hope to cover today is reviewing some of this evidence in terms of a prioritization, as well as identifying some potential barriers of where we go from here. And of course, there are some barriers including how we define the issue, potential multiple pathways, and what can be done about it. So let's first talk about what we mean by, or what I mean by prioritization. Because for some people, when I say prioritization, they may be thinking large-scale interventions or even legislation of good relationships for all. And of course, this kind of perspective might be met with or perceived to be premature, naive, or even unnecessary involvement of government in personal matters. But quite simply, what I mean by prioritization refers to how the CDC defines this, and that is resources, time, and energy to those issues that are deemed most critical and practical to address. So what is the criteria for prioritization then? So I'm going to really be drawing on some very commonly used criteria in this area. So, and this includes, quite simply, the size of the problem, the seriousness of the problem, and the estimated effectiveness of the solution. So before we can go through this criteria, it's critical that we define what exactly the problem is. How do we prioritize something if we are having a hard time defining it? So what exactly is the issue? Is it the perception of loneliness? Is it lacking social contact, interaction, or perceived support? Maybe it is lacking a close, intimate partner or someone in the home to rely on in times of need. Maybe it's being in a strained relationship. I hope you can see from even this incomplete list that This lack of precision may be a potential barrier not only to major organizations prioritizing this, but also individual prioritization. So when we look to the research literature, what is the evidence based on? And we can see that the evidence has also similarly used a wide range of measures. These measures can be broadly categorized into three major areas of measurement. The first has to do with what I refer to as structural aspects of relationships. This gets at the existence and interconnections among different social ties and roles. So this would include measurements such as size of social network or social integration, marital status, living alone. But there's also functional aspects of relationships. So this has to do with what do our relationships actually do? And the actual or perceived availability of resources by our relationships. And then, of course, also there's quality, the positive and negative qualities of our relationships. So examples would include things like relationship satisfaction, conflict, and ambivalence. One thing I should point out is that while there is a variety of measures that have been used, all of them have been linked to morbidity and mortality. So important health indicators. But what's interesting is that the correlations between them aren't very high, suggesting that all of these aspects of relationships are having an impact on health, but may be operating through different mechanisms. So to try and address this issue of a lack of precision around defining the issue, my colleagues and I have proposed the term social connection to use as an umbrella term that encompasses the structural, functional, and quality aspects of relationships, suggesting that the presence or absence of others and the way in which we connect in that way is important. What they do or perceive to be available is important, and the quality of those relationships are important. What we also suggest is that this is on a continuum, so that high levels of connection would be associated with low risk or protection, whereas low levels of social connection would be associated with high risk. So to define the problem is lacking social connection or social disconnection. So back to that criteria around how we prioritize. What exactly is the size of the problem? Is there evidence that a significant portion of the population lacks social connection? So when we look to this, of course, there are a variety of indicators as well, right? And so one of the ways in which we can do this is looking specifically at indicators of loneliness. So for instance, AARP, data from AARP suggests that over 1/3 of older adults are lonely. And if we look to some surveys that have come out just this year, there was a Cigna report, a Kaiser report, and a BBC report that suggests some varying degrees of this as well. So one thing that is potentially problematic with this is that there are different measurement approaches being used, so it's hard to know. Because this isn't routinely collected, it's a little bit more difficult to estimate precisely. One thing I should point out is that the Kaiser and BBC surveys both included other countries other than the US. Now, if we look to other kinds of indicators or potential indicators of social connection, we can look to some that are a bit more objective, those that are more routinely collected, and we can look at demographics via census records. So for instance, more than a quarter of US adults live alone, more than half are unmarried. The divorce rate is approximately 40%, 3 in 10 are distressed, and there's evidence that the majority of Americans do not participate in social groups. Now, one thing I want to point out is that these demographic factors, of course, are somewhat crude indicators. So, for instance, you can live alone and be unmarried and not necessarily socially disconnected or lonely. However, as I'll point out, some of these demographic factors are nonetheless risk factors for loneliness and independent risk factors for premature mortality. So we not only have evidence that there is a significant portion of the population that is affected by this, but we also have evidence that this is comparable with other kinds of risk factors that receive considerable attention and resources. So if we look at, and of course this arrow represents that variability in the estimates from the low to the high end of estimates for loneliness. But what we can see is that it's comparable to the prevalence rates of obesity and physical inactivity, and exceeds that of the percentage of adult smokers in the population. So in terms of the extent to which this has an effect on our population, we have good evidence that there is a significant portion affected. There's also, is there evidence around urgency? Is there evidence that loneliness and social isolation are increasing? So while there is some evidence that suggests that loneliness is on the rise, again, it's very difficult given that this is not routinely collected and measurement approaches in some cases are not directly comparable. But when we look to some of these other kinds of factors, we do have good evidence that this is on the rise. So for instance, those living alone has increased. Marriage is decreasing, childlessness is decreasing, and the average size of social networks has declined as well. Now, when you take together some of these, what this suggests is that with an increasing aging population, what this suggests is that we also will have reduced resources to draw upon in older age. Thus, we have strong evidence that a significant portion of the population lacks social connection, and while not entirely clear, there are some indicators that this is on the rise. So what about the seriousness of the problem? One of the primary ways to address this is to look at the risk for premature mortality. So in order to do this, we looked at the epidemiological data to look at how, and all of the epidemiological data worldwide, and looked at this meta-analytically. So I'm sure many of you know what a meta-analysis is, but for those of you who may be less familiar, let me just explain why meta-analytic data might be important. So I'm sure all of you have ordered or shopped online, right? And how do we know whether to trust whether it's a good product or not? We look at the reviews, right? But we're not just interested in whether it gets good reviews or not. We want to know if there were a lot of reviews, right? And we have a lot more confidence in the product that has lots and lots of reviews compared to the product that has very few reviews. And similarly, we want to do that for scientific evidence as well. So when we have lots and lots of evidence all pointing in the same direction, we can have a lot more confidence in that relative to fewer studies. So I've conducted two meta-analyses, or analyses. The first one looked more broadly at the effect of social relationships on risk for mortality. So this included 148 prospective studies with over 300,000 participants. The second one that I conducted, although it had fewer studies, included over 3.4 million participants. And this was based on the available data published worldwide. So what did we find? In the first meta-analysis, what we found was that social connection led to a 50% reduction in risk for early mortality. And this was, of course, adjusting for age and initial health status, because, of course, if we are ill or as we age, we're more likely to die. So we adjusted for those. So we weren't just interested in, okay, that's significant, but what exactly does 50% mean, right? So we wanted to know exactly how this stacked up to other kinds of things that we know impacts our health and longevity. So we went to other kinds of lifestyle and environmental factors that we regularly know to be quite important, things like smoking and alcohol consumption, physical activity, obesity, air pollution. And as we can see, these all have a significant impact, but some are have a stronger influence on mortality than others. So where does social connections stack up? And is the magnitude strong enough that we need to take this as seriously as we do these others? So the blue bars here represent those same lifestyle and environmental factors. And the orange bars refer to different ways of calculating that effect of social connection. As we can see, not only are they comparable, but it exceeds, in many cases, the effect on mortality of some of these other hallowed factors. The one that seems to get quoted the most often is that lacking social connection is comparable to smoking up to 15 cigarettes per day. Now, keep in mind, there's been even more data that has been published since then, and additional meta-analyses that include hundreds of studies and literally millions of participants. So we tried to summarize this data as well. And I'm not going to go through every line of this, and don't feel like you need to, but I do want to just highlight two things. So in terms of looking at the different kinds of indicators of social connection to see if some were more robust predictors than others, what we found was that they were generally all predictive or significant predictors except for one. Interestingly, that was received social support. And so that one, and we can maybe in the Q&A talk about some potential reasons why that might be. But interestingly, the most robust of these was complex measures of social integration that was associated with a 91% increase odds of survival. And complex measures of social integration, interestingly, encompass a variety of those indicators that I mentioned earlier. So in the second meta-analysis that I did, I looked specifically at social deficits. So social isolation, loneliness, and living alone. And there's been a lot of debate whether it's the objective or subjective aspect of this that is what we need to be taking most seriously. And so what we found was that all of them were significant predictors of premature mortality, and that they were equivalently so. That doesn't mean that they measure the same thing, but rather that they equivalently predict risk. What was interesting is that these social deficits, although significant predictors in their own right, it was smaller than the overall effect of social connections, and quite a bit smaller than complex social integration, suggesting that perhaps the protective effects of being socially connected may be stronger than the risk of being disconnected. So if we take that same comparison level and benchmark them again across a variety of indicators, again, in the orange bars represent different ways of looking at social connection, and the blue bars are leading health indicators. While we see that they do vary in the degree to which they predict mortality, they again are on par with these others that receive considerable attention and resources. And I'll just point out the ones that are at the very bottom that all of them outweigh are physical activity, obesity, and air pollution, things that we take very, very seriously. So what does the evidence tell us? This is robust relative to other risk factors. It's consistent across age, gender, initial health status, cause of death, and even country of origin. Both subjective and objective indicators predict risk, and the evidence points to a continuous and not a dichotomous issue. So let me explain what I mean by that. So the evidence doesn't support a threshold effect. So a threshold effect is this idea that there is some kind of threshold by which below that you're at risk, but above that you're fine. So for instance, I'm constantly being asked, okay, just how many friends do I need to be healthy, right? As if there's this magic number, right? Below it, you're at risk, and beyond that, you're fine. But it also implies that beyond it, there's no added benefit. But what the data suggests is that this is really much more of a continuous effect. And in fact, there's data from 4 nationally representative samples, and importantly, these are across structural, functional, and quality indicators. It's also across early and late life. They find a dose-response effect. What a dose-response effect means is that for every level of increase in social connection, there was a level of protection associated with that, which suggests that there is an enormous power to be had in terms of the protective effects of being socially connected that we should not ignore. So some of you may be wondering, well, how exactly does being socially connected lead to better health and longevity? It might seem like too far of a stretch. Is this just some kind of correlation, or do we actually know of mechanisms by which this occurs? And there have been identified multiple mechanisms. I'm just going to highlight a few. So one of the ways that is probably most widely recognized by the medical community, or may seem most intuitive to most people, is the influence on health-related behaviors. So our relationships can promote healthier kinds of behaviors and discourage or deter risky kinds of behaviors. So this would include things like smoking, alcohol consumption, and substance abuse. But of course, we also know that it can go the other way. Diet and exercise and sleep. So what I mean by this is that our relationships might encourage us to get more sleep, to eat better, to go see a doctor when we need one, and to take our medicine, and to follow up and go to those follow-up appointments. So these are all ways in which our relationships influence these kinds of health-related behaviors. But interestingly, all of the data that I have just summarized in terms of premature mortality, most of this evidence statistically controlled for lifestyle factors. What I mean by that is that these effects are independent of common lifestyle factors like smoking and exercise and what might be otherwise alternative explanations, which suggests that our relationships have an effect over and above any effect that they might have on just these kinds of health behaviors. What are the ways in which that might be? This could be through stress reduction. There's a wide literature on the buffering effects of social support. Our relationships also provide a sense of safety and a sense of meaning and purpose in our lives. And this, in turn, could lead to better self-care and less risk-taking. We have a growing body of evidence showing the direct influence on health-relevant physiology, including cardiovascular, neuroendocrine, and immune functioning. It's been linked to cellular aging and rates of cognitive decline. So we have very strong evidence that being socially connected, or lack thereof, influences health and ultimately longevity. The big challenge that we face, and before I move on, I forgot to mention that there's also evidence that recently has come out on the economic costs associated with this. So last spring, AARP did a large survey where they found that this led to, I believe it was $8.6 billion, or maybe it was 6.7, regardless, billions of dollars in added Medicare costs. So this has an economic cost as well. So what do we do about it, right? And this is the huge challenge that we face right now. And so this really gets to the last component of prioritization, and that is the effectiveness of solutions. So my colleagues and I, for the last couple years now, have been working on another meta-analysis looking at interventions and mortality. And we're not quite done, but what I can tell you is that the evidence is mixed. And so it's really important to understand what works and what doesn't. So if we look back to the data that has established why this is important, it has a number of implications for interventions. And there seems to be a disconnect between the science and some of the interventions or implementation strategies. First of all, we need to recognize that the existing data that establish its importance are based on people's existing relationships, their existing close relationships, their existing social networks. And yet the majority of interventions are with complete strangers. We also know that relationship quality is important. So while there are protective effects of being socially connected, in fact, there's times when I will report or describe this research, and someone will come back and say, relationships are good for us. Well, you haven't met my family. And so we do need to absolutely acknowledge that relationship quality matters. And there's data that suggests that negativity in relationship is associated with greater risk. And so many of these interventions don't account for relationship quality. And so, for instance, if you are simply increasing social contact without acknowledging this, you may have unintended negative effects. Also, most of the interventions are focused on social deficits. And we need to acknowledge that loneliness and social isolation are not the same thing. So loneliness is this perception or feeling alone, or the discrepancy between one's desired and actual level of connection, whereas social isolation is objectively either lacking connections or infrequent contact with those connections. So you can be lonely and not alone. People are often lonely around other people, in crowds, at parties. But you can also be alone and not lonely. Some people take great pleasure in their solitude. But what we need to recognize is the way to address one may not necessarily help the other. So if we simply increase social contact, it certainly will address social isolation, but not necessarily loneliness. So we also have evidence that a multi-factor approach is needed, and yet the majority of these interventions do not take a multi-factor approach. So what do I mean by a multi-factor approach? So one of the things that we need to realize is that a number of, in addition to social connection being this complex, multifactorial construct, that it doesn't have a single causal mechanism, okay? But neither do many public health issues that we take very seriously. So here's just an example of obesity. We know that it's not one single factor that influences obesity, right? Here are just a few examples. And so if we think about the potential risk factors for isolation and loneliness, we can see that there are a number that have been identified, including poor health and well-being. So if there's mobility impairments, it's harder to get out and be involved. For example, life transitions, whether it's leaving for college or leaving the workplace, or loss of a family member, or something like discrimination or communication barriers. The way in which you would address one may not be effective for another. So someone whose social isolation may be caused by untreated hearing loss, it would be approached very differently than someone who has just lost a spouse. And so we have to think about the different kinds of approaches that we need to take for this. We also know that there are multiple pathways. So this is a model that we put together, but that some pathways may be more modifiable than others. And so if we can address those that may be more easily modifiable, we may have more success. So I want to go back to that analogy I proposed earlier in this talk, where I proposed that social connection is a fundamental human need. And remember, I mentioned that loneliness has been compared to hunger or thirst as a biological manifestation or motive to reconnect socially. If we extend that analogy further, we also need to recognize that we need to address the objective lack, right? Kind of like to try and address world hunger, we kind of need to figure out access to food, right? And so we actually need to consider the objective lack of social connections, and that's where isolation might fall in. Loneliness would then be the symptom, right, or the motivation. But just like we need food and water to survive, quality also matters. Water can be dirty or tainted. Food can be spoiled. and poor quality can put you at risk. So I hope by extending this analogy, we can recognize that social connection needs to be addressed in this comprehensive way, because if we only address one of these, we are going to potentially miss risk associated with the others. So here's probably the, million or billion-dollar question. What is the role of technology? And this is a tough one. And partly because the technology is outpacing the data. And one of the things, and of course this is a hotly debated issue, but we can all, I think there's fairly well agreement or consensus that it has influenced the way in which we interact socially. And in fact, there's data from the Pew organization that suggests that this is the primary way in which people interact socially now. So how is this influencing the effect? So it's really difficult to say, but one of the things we need to recognize is that if, for instance, if we take the often cited year of 2012 as the point in which more than 50% or the majority of Americans have had smartphones, this has only been 6 years. We have no idea the long-term effects of this. We don't have the data. Keep in mind that my meta-analyses, these were prospective studies, meaning they followed people over time. And these were often over decades. So these existed prior to the widespread use of some of these technologies. But we also need to recognize that technology is more than smartphones, and technology is more than Facebook. And that there is a wide range of technology that we need to better understand in terms of its role in the problem, but also its role in the solution. So we face a number of opportunities and challenges. And if we look to the challenge also of interventions, is that most of the interventions have been individual-based. And if we look to other kinds of public health issues, what we see is that these kinds of efforts have had less success than, say, preventative efforts and those efforts that are done at a community and societal level. If we look to the CDC as a model, what they suggest is that that some of these efforts, the more intensive and the more narrow, when we address an issue, when it already becomes very serious, so tertiary level interventions are the most labor intensive, the most costly, and the least effective. And so we really need to start thinking more seriously about preventative efforts. So one way to think about this is if we go back to that idea that social connection is on a continuum and from high to low, and assuming this is normally distributed, what we can acknowledge is that the majority of our interventions are aimed at those on the extreme low end. And that's not to say we shouldn't be, because of course these are the people that are at the highest risk. But if we recall that there is a dose-response effect, we are in essence ignoring the potential to have meaningful impact on the rest of the distribution. So if we look to a broader population base that gets across the risk trajectory, population-based interventions may be able to shift the distribution, having a much larger impact. So we could borrow from public health the social ecological model and really consider efforts that are individual, interpersonal, organizational, community, and societal, and that at each of these levels there are opportunities to intervene that could have a lasting impact. Now, some of you may have seen our 19th Surgeon General in the media, who has also been arguing that we need to make fostering social connection a national strategic priority. So what exactly would a strategic priority entail? So I'm just going to offer a few potential policy and practice recommendations. So the first is better screening. So as I mentioned, we don't have good prevalence rates on loneliness or how this has changed over time because it's not routinely collected. But of course, that is just one indicator, as I've also talked about. The Institute of Medicine reviewed evidence around the different factors that impact health and published recommendations for the inclusion of social connection in all electronic health records. But unfortunately, despite this recommendation, this is not currently occurring. Another recommendation that I suggest, and I know it's a bold one, it might even be a controversial one, and that is consensus guidelines for social connection. So just like we have recommendations around nutrition and physical activity and sleep, that we have recommendations on social connection. And so one of the reasons I suggest this is because these guidelines can help people, the population, everyone, recognize that how they're doing on this, right? So when we have these nutritional guidelines, we might recognize, okay, I'm not getting my veggies in today, or I'm doing really well on this, but I'm not so much on that. But we have a good sense of where we're at. Whereas without these for social connection, most people don't really know whether they're the extent of their risk level. Now, I acknowledge that these recommendations would be imperfect. Similarly, as the others are imperfect because these are complex. So these would need to be expert panel convened to establish these that would be based on both quantity and quality. And they would need to be evidence-based and subject to periodic review. So just as nutrition recommendations have changed over the years based on the evidence, that we would also need to periodically review these. But this would also then change the national conversation around this and would have cascading effects into education and healthcare as well. So by doing so, this would then be taken more seriously in education. So we now have, as I mentioned, robust evidence on the risk. So to raise awareness, this may need to be included in education, whether it comes from K through 12 to medical training. This also, we can think about policy recommendations or practice recommendations in healthcare, the way in which it is communicated to patients, but also in a way that is may have preventative effects, as well as identifying those who are at risk. Of course, the workplace is another opportunity to have a touch point because the majority of Americans spend more time in the workplace than they do with their own friends and family. And so the workplace may have a very high impact. And then, of course, there's room for the built environment, the kinds of things that spaces that we design. they often talk about third spaces. So the home and the workplace being the first two. And what are our third spaces? Those used to be churches and community organizations. But with declining rates of those, participation in both of those third spaces, we need to really figure out, is our third space online? Is our third space at Starbucks? Where are our third spaces? And how can we design spaces around social connection? We also need to assemble the capability for large-scale change by partnering with community stakeholders. There are a number of organizations that are committed to this and can have potential impact. But we also need to recognize that there needs to be evaluation all along the way, and that there needs to be systematic evaluation. Now, recall at the very beginning when I talked about prioritization, I maybe perhaps flippantly suggested that legislation could occur. And interestingly, legislation has occurred. So let me tell you about one example. When I testified before the US Senate Committee on Aging, one of the results of this was the proposing of the Over-the-Counter Hearing Aid Act. So we know that untreated hearing loss is a risk factor for isolation and loneliness. If you can't hear or are having difficulty hearing, it's very difficult to be part of a conversation, and it can be easy to withdraw socially and become disconnected and isolated. And so Senator Warren proposed this legislation, and it was later signed into law by President Trump. So this was a bipartisan effort. And of course, it's yet to be seen to what extent this reduces isolation and loneliness. But nonetheless, this is an example of legislation that has occurred that has attempted to address this issue that also doesn't come at the cost of personal choice or privacy. So in conclusion, we know that social disconnection significantly increases the risk for premature mortality, and social connection is a robust protective factor. We also know that a significant portion of the population is socially disconnected and that it may be increasing. The interventions to reduce risk have mixed evidence, but it's only through greater prioritization and greater resources that we will actually be able to tackle this important issue. So to end, I have a picture I want to show you. This past summer, I took college students, well, the past 2 summers, on a study abroad. I don't know if any of you have been on a study abroad program. My study abroad happened to take them to a couple of the blue zones, or these hot spots of longevity. This happens to be in Sardinia, Italy. It has the largest concentration of male centenarians in the world. And we are interested in some of the factors that might be contributing to their health and longevity. And so of course, there are a variety of factors. But one of the things that I was struck by is that this community was a very small, very tight-knit, very close community where everyone looked out for each other. As you'll notice in this photo, I was struck by the fact that there's keys in the door. And I asked about this. I said, why do people leave keys in their door? And he said, well, of course, their neighbor might need something. And I was struck by the incredible level of trust that existed in this community. And in thinking about how social connections influence health, I was thinking about how we need to take our relationships seriously, like we do these others, and that it's our everyday little actions that have a cumulative effect on our overall long-term health. But I am also recognizing it's these small moments of connection, these little things that have cumulative effects on the trust also that we have in our society. And it's my hope that through greater social connection that we can not only have healthier communities, but this can also help to rebuild trust in our societies and the fraying fabric of our society so that we can live in stronger, more connected communities. Thank you. Yeah.
One is, I'm very zealous to use the term developmentally informed. We haven't used the term child or childhood even once. That's what happened to people who always children. We are zealous to talk about developmental perspective. Because you don't just wake up one day
Exactly.
lonely or isolated. Attachment issues, temperament issues. By the way, don't tell anyone, but I'm developing an app for children called Go Out and Play with Your Friends. Because all those kids who just spend time in hobbies, their mutual friends are just very scientific American. You can have up to 150 friends. What is part of that?
Yeah.
So, the point is that every disorder is highly heterogeneous. So we need most probably look at different age groups. For example, in disclosure, I'm an empty nester. Two of my kids are in college. So you guys, please call home once a week. Parents are busy. It's a very important issue in terms of connectivity.
Oh, and I agree 100%. And in fact, the data suggests that this is consistent across age. And yeah, this does not discriminate. It can affect everyone. And it doesn't just happen in a vacuum. I'm absolutely in agreement with you.
The intervention should be age-specific.
Yeah.
The second issue, body coziness, which is the ultimate epigenetic disaster. I mean, diseases of consumption, such as substance abuse, obesity, and so forth. So I kind of wonder about how it's going to look like. It's almost like a natural selection process, meaning that you can't really identify some genetic ability, but certain behaviors keep on repeating. And if, let's say, you have obese children, per generation, they increase the likelihood that their children are obese. So, what do you think about the issue of loneliness in terms of
Yeah, there are some that are looking into various mechanisms of social sensitivity and whether that may be a variety of bioindicators as well as, say, early childhood experiences and how that may impact that. And so I know that there are a number of people who are approaching it in that way. But I think it's also early enough that I don't know that we have a large body of evidence to say the effect yet. But I think it's really intriguing, and I really appreciate that.
Any evidence on, or how much evidence is there on inflammation and loneliness, and also on the idea of disease progression?
Yeah.
Possibly a disease will progress more slowly, like Alzheimer's or other diseases. What might progress more slowly if there's a high degree of social.
Ooh, that's a great question. First, I can say that there is evidence on inflammation. I believe it's by Steve Cole, where there's evidence that chronic levels of loneliness are associated with inflammation, which, of course, inflammation puts people at risk for a variety of inflammatory-related diseases. And as far as progression goes, the natural disease course can vary from disease to disease. My research, of course, was based on all-cause mortality, and it's a little bit side tangential to your question, but I think it's important because it's related to the previous question, is that I should mention that the evidence that I reported is on either all-cause mortality or disease-specific mortality. It did not include mortality related to suicide or accidents or violence. And that's not to say that this is not related to those others, but rather at the time it was not widely acknowledged that it was related to disease-related mortality. And so we were afraid that it might be dismissed as being completely driven by suicide. And so that's why that decision was made. So these data were related to disease. We did not find any difference between diseases, but that's looking at mortality as the outcome, not progression. And I think you're making a very good point that we probably need a little bit better understanding, because that also gives us insight into which points along the development might be best to intervene. No. In terms of the meta-analysis, you're gathering all of the published data, all of the data that's been published worldwide on it. And so what they did is they measured social relationships or whatever indicator of social connection and all of the other potential confounding factors at the start, and then followed people over time and then measured whether they were alive or dead. And so the idea are these indicators of social connection predicting who's alive and who's dead at the follow-up? And so one of the nice things about it is, death is pretty unambiguous. There's nothing subjective or about it. So these, because they were followed over time, we know the direction of the effect. Because of course, some people argue, is it possible that that people who are unwell may be more socially isolated, and it's really reverse causality. But we're able to, because most of these were initially healthy participants. And those that did have clinical-based populations, we were able, regardless of whether they were healthy or well, those who are more socially connected lived longer than the others. So that's how does that help clarify the data? Okay.